Hello, my name is Dr. Mende. So we continue with our series on cranial maxillary division of trigeminal, and we said it's located on the lateral wall of the cavernous sinus, usually gives a branch to supply the dura mater, and eventually exits the cranium to foramen rotundum. After that, it enters the pterygopalatine foramen. So usually it gives some branches like posterior superior alveolar to the maxillary sinus and the upper molars. It also has a zygomatic branch that will divide into zygomaticotemporal and zygomaticofacial, supplying the skin over the zygoma. Orbital nerve that passes through the canal and exits through the infraorbital foramen, and this innervates the maxillary sinus and gives branches such as mid-superior alveolar and anterior superior alveolar to the premolars and incisors and canines. It also innervates the midface and lower lid conjunctiva, the skin of the lower eyelid, as well as the nose and the upper lip. Then, from the pterygopalatine ganglion, this maxillary nerve gives some branches. So it can go into the infraorbital fissure, and here it will give orbital branches to the periosteum of the orbit. Then it can also pass through the sphenopalatine foramen, while at the sphenopalatine foramen, it can give nasopalatine branches. These supply the posterior part of the nasal septum and the gum behind the incisor via the incisive foramen. Then you can also have the posterior superior nasal nerve to the nose and the nasal septum. Then we have pharyngeal branches supplying the mucosa of the nasopharynx, the greater palatine nerve onto the lateral nasal wall and the hard palate via the greater palatine foramen. And also we have lesser palatine nerves that will supply the soft palate. So greater palatine supplies the hard palate, while lesser palatine supplies the soft palate via the lesser palatine foramen. So this is what we are discussing. Within the middle cranial fossa, that's where you have trigeminal nerve dividing into ophthalmic, maxillary, and mandibular division. Maxillary will exit through foramen rotundum and then give some branches. Then you can have a branch through the inferior orbital fissure that will give the zygomaticofacial and the zygomaticotemporal, and you can have part of the nerve passing through the pterygopalatine ganglion, okay, that will give you sphenopalatine foramen, okay, and then you have pharyngeal nerves, you have your greater palatine to the hard palate and lesser palatine to the soft palate. But you also have through the infraorbital canal, you have your infraorbital nerve through the infraorbital foramen. And we go to the mandibular division of trigeminal. It has two components, the special visceral efferent and general somatic afferent. The special visceral efferent is to the masticatory muscles, motor efferent. Then the general somatic afferent, you get sensation from the tongue, teeth, and the face. So mandibular exits the cranium via foramen ovale, together with accessory meningeal artery, the lesser petrosal nerve, and the emissary vein. So those are the four contents of the foramen ovale. Mandibular division of trigeminal, accessory meningeal artery, lesser petrosal nerve, and emissary veins. And it gives meningeal branch called the nerva spinosum. So nerva spinosum is a nerve of the branch of mandibular division to the dura mater, and also gives a nerve to medial pterygoid. After it has given these two branches, mandibular division divides into anterior and posterior divisions. So the anterior division supplies muscles of mastication. This include nerve to lateral pterygoid, deep temporal, nerve to masseter, buccal nerve, tensor tympani, levator palatini. So these ones will be innervated by the anterior division of mandibular nerve. So this is what we are talking about. The mandibular nerve will exit through foramen ovale, then give nerva spinosum to the dura and nerve to medial pterygoid. After that, it divides into anterior and posterior division. So the anterior division innervates muscles of mastication. So it's mainly motor, temporalis, lateral pterygoid, masseter, and buccal. While the posterior division is mainly sensory, so you get your auriculotemporal nerve, inferior alveolar nerve, then lingual nerve, and nerve to mylohyoid. This inferior alveolar nerve is what eventually will give the mental nerve. So this posterior division has different branches. We have auriculotemporal. What does it supply? Temporomandibular joint, the external acoustic meatus, the external surface of the auricle, and the parotid gland. It gives secretomotor fibers to the parotid gland to make it secrete. Then we also have a lingual branch. This supplies the mucous membrane on the floor of the mouth and the lingual gum. And it also supplies the secretomotor fibers to the submandibular gland and provides general somatic afferent, okay, pain and temperature sensation on the anterior two-thirds of the tongue, lingual branch of posterior division of mandibular nerve. Then we have inferior alveolar. It gives nerve to mylohyoid, okay. Then so it supplies mylohyoid and anterior bailey of digastric. This nerve to mylohyoid supplies mylohyoid and anterior bailey of digastric. Inferior alveolar after that passes through the mandibular foramen, then from mandibular foramen into the mandibular canal, then supplies the 2 premolars and 3 molars, as well as the lower incisors and the canines. Then after that, the inferior alveolar now exits through mental foramen as mental nerve, and this mental nerve innervates the skin and the mucosa of the lower lip and the gum. So this is your mandibular nerve. You can see here, okay. Then through foramen ovale, you give a nervus spinosum to the dura mater, and it will also give a nerve to medial pterygoid, then divides into anterior and posterior divisions. So you have your anterior division to the muscles of mastication, such as lateral pterygoid, anterior division to lateral pterygoid, masseter, temporalis. So basically this is your mandibular nerve, okay. This is your maxillary and this is your ophthalmic, and you can see inferior alveolar, it will enter through mandibular foramen, then exit finally as mental nerve supplying the skin over the chin at this level. So what are the applied anatomy aspects? So when you have lesion of the mandibular division, you get flaccid paralysis of muscles of mastication. It's innervating muscles of mastication. So the jaw will deviate to the side of lesion. Then you also get sensory loss in the area of distribution of this mandibular nerve, and there'll be unilateral loss in the strength of the bite. So when you have upper motor lesion of the nerves that are controlling this mandibular nerve, from the cortex, cerebral cortex, we have upper motor neurons from cerebral cortex to control this mandibular nerve. So when these upper motor nerves are affected, you get exaggerated jaw reflexes. Remember what you talked about upper motor neuron lesions. You get exaggerated reflexes. So these corticobulbar projections, when they're affected, you get bilateral weakness in unilateral lesion. Then we have what we call trigeminal neuralgia. It's when you have shooting pain in the area of supply by the affected division of the trigeminal nerve. So like then you can have trigeminal ganglionitis, like in herpes zoster, as you can see here. These are lesions, ulcerated skin lesions. They are usually characterized by pain. So lesions on the skin or the mucous membrane in the distribution of the trigeminal nerve. So the most affected is usually the ophthalmic division. Then we go to the 6th cranial nerve, which is abducens. It carries general somatic efferent information. So general somatic efferent. And abducens is located in the pontine tegmentum deep to facial collicula. Remember we said facial colliculus is the abducens nucleus that is surrounded by facial nerve going round it. So it's deep to facial colliculus, which is located on the floor of the 4th ventricle. What's the intracranial course of abducens? Ventrally, it goes ventrally through the pons, and the sulcus between the caudal border of the pons and the superior border of the pyramid. That's where you find it. So it's located on the sulcus between the caudal border of pons and superior border of the pyramid of the medulla. And then after that, we see it between the anterior inferior cerebellar artery and the labyrinthine artery before you now see the abducens nerve going into the pontine cistern. Then it pierces the meninges. After that, it's located within the cavernous sinus. So that's the intracranial course of abducens nerve. Through the pons, between pons and the pyramid, between anterior inferior cerebellar artery and labyrinthine artery, it enters the pontine cistern, pierces the meninges later, and you see it as a content of the cavernous sinus. So here it is, together with the siphon of internal carotid artery, they form contents of the cavernous sinus. And the extracranial course, abducens nerve, will exit through superior orbital fissure together with oculomotor, trochlear, ophthalmic nerve, and ophthalmic vein. It's located within the common tendinous ring, and it goes to innervate the lateral rectus muscle that causes lateral or outward movement of the eye. So this is the abducens nerve, nucleus is at the floor of the fourth ventricle within the facial colliculi. Then it lives between the lower portion of the pons and the pyramid of the medulla. Then you can see it in the subarachnoid space. Then it will enter the cavernous sinus. We see it within the common tendinous ring before it goes to innervate the lateral rectus muscle. What are the sites of injury? Any vascular lesion at the pons will affect it. When you have aneurysms of the basilar artery, can affect the abducens nerve. Tumors of the meninges, cavernous sinus thrombosis because it's a content, base of skull fracture like any cranial nerve, aneurysm of the internal carotid artery within the cavernous sinus because they are the two contents in there, then increase intracranial pressure. So all these are the causes and sites of injury to the abducens nerve. And what does abducens nerve do? It is supposed to cause the eye to move towards the lateral aspect. Okay, this is a normal eye, so there's equal action of medial rectus and lateral rectus, so it's maintained at the center. But here the lateral rectus is not working, so medial rectus is acting unopposed, so you get this medial strabismus. So this abducens nerve palsy has lateral rectus paralysis characterized by medial strabismus, where there's an opposed action of medial rectus. So there'll be double vision. Whatever this eye is seeing and this will be different, so you get diplopia. And the patient now has to rotate the head towards the affected side to avoid diplopia. So there is usually limited lateral movement of the eye. Superior and inferior oblique muscles have a minor abductive component. So there will be some abduction, but it's very limited. This is from superior and inferior oblique. Superior oblique is by trochlea, inferior oblique is innervated by oculomotor nerve. So this, you can see, this eye has abducens nerve palsy. You cannot abduct. This one has trochlear nerve palsy. Look at that extorsion that has happened. Okay. So next we shall discuss the facial nerve. Thank you.